Hello and welcome back to another anaesthesia step-by-step tutorial. Today we're looking at bradycardia in the operating theatre. As per usual, your patient is beautifully asleep and comfortable with full AA-GBI monitoring and you as their attentive anaesthetist at the ready, when suddenly the monitor starts beeping, alerting you to a worryingly low heart rate. What do? Now the most likely cause of a sudden, genuine bradycardia is a stimulus, usually surgical, causing a vagal surge and dropping the sinoatrial node activity and dropping the heart rate. A classic example is cervical dilatation in gynecological surgery. So politely ask your surgical colleague to stop what they're doing and see if this rectifies the issue. While you're asking them to pause, check the patient's pulse, as this determines where you go next. If there is no palpable pulse, the scenario is now ALS management of cardiac arrest, which we'll cover separately. If not, you can move on. We want to ensure we're giving the patient adequate oxygen while we troubleshoot any significant physiological derangement, as the end goal is always adequate delivery of oxygen to the tissues. So quickly check your circuit, flows, FiO2, and check that the bellows or the bag are moving as they should, and that your airway is still where you left it. Now we're going to continue down our diagnostic ABC assessment, but we're going to treat as we go by giving something to treat the bradycardia. Atropine and glycopyrrolate are the most commonly used, with glycopyrrolate being a slower, more gentle option, and atropine being a rather sledgehammer approach that might then result in a significant tachycardia, but will get you out of trouble quickly. Ephedrine is another option if there's also low blood pressure, while isoprenaline infusions and the use of adrenaline are usually reserved for ongoing bradycardia despite these other options or a peri-arrest situation. Once you've given something, you can move on and assess breathing in the usual fashion, checking for symmetry and added sounds, and your adequacy of ventilation, including saturations, end-tidal CO2 and tidal volumes, as well as airway pressures. Now, circulation is clearly crucial in this scenario, and we're particularly interested in the rate and the rhythm. Firstly, is it a characteristic pattern such as first-degree heart block, slow atrial fibrillation, or a sinus bradycardia? And secondly, has it improved with your intervention yet? If it has, then it's fairly reassuring that this was a one-off due to a particular stimulus or maybe a drug reaction, but if it is continuing to be an issue, then we need to think about other causes, which can be found in the Quick Reference Handbook. Check the depth of anaesthesia is adequate but not too deep, as this can also cause bradycardia, and then consider further agents from the above list. If nothing is working, then you may need to think about pacing. This can be done transcutaneously using the defibrillator pads. Just make sure you've got the pacing mode selected at the right rate, and then slowly increase the current from 60 milliamps upwards until both electrical and mechanical capture are confirmed. As always, use the help available to you by grabbing the Quick Reference Handbook and calling for senior support earlier rather than later. We hope you've found this tutorial useful. If you did, please hit the like button. If you didn't, please comment why so we can improve our videos for you, and we'll see you next time.